Now, the next session, I do in managing hepatitis B patients in the practice. So we already have, we heard from Dr. Carla Coffin, so she will be in the panel. We have Dr. Wong already, and I want to introduce Dr. Ma and Dr. Cooper. So Dr. Cooper is an infectious disease specialist and professor of medicine from University of Ottawa. He's also the division head and the director of the Ottawa Hospital Virus Hepatitis Program. So he's also senior scientist and do a lot of research in viral hepatitis, including HIV, Hep B and C, and COVID. And then Dr. Ma, he is a hepatologist and professor of medicine from University of Alberta. So received numerous teaching award, and he's actually spanning from treating viral hepatitis, dealing with even liver transplants. Also have a lot of research interests in chronic hepatitis B and MAS. So he'd also contribute to establishing the fatty liver pathway in Alberta. So, so this is Meet the Expert panel. So I'll start out with asking, maybe I'll go by alphabetical order, like Dr. Cooper. So in your practice, what do you feel is the major challenges in really managing Hep B patients? There might be provincial differences, but just want to hear from you. And then I'm going to go around the table, ask about how everyone feel in different province.
Great, sure. Happy to answer that really important question. And firstly, I really appreciate the opportunity to participate in this, and it's great to see a lot of familiar faces of friends and colleagues. So, there's lots of challenges. I would say that a key one is related to finances. It's true that the oral hepatitis B medications are relatively inexpensive compared to a lot of other medications out there, but there's still a challenge for so many of my patients where even $150 a month is just too much to afford, and that precludes them from starting on medications that I think they should be on and they want to be on as well, or it creates considerable hardship for them. So, keeping in mind that these medications have been around for decades, they're around the world globally, they're available, and they can be made in a very inexpensively. I do question the price tag attached with them, and I think we should all do whatever we can to try and find ways to reduce the cost for these, so that everybody who wants to be on these medications and derive the benefit can do that.
Mhm. Dr. Coffin, like from the east, now move to the west side.
Thanks, Hin Hin. Nice to see you, Curtis and Meg. Yes, I agree the same, that the cost of medications is a big financial barrier. Another challenge I find is that getting regular checkups, like going for regular blood work and getting regular ultrasounds, is often a challenge for many people that we see in our practice. And if they're not receiving antiviral therapy, often we ask that they, follow up with their family doctor to order the required blood work and to get regular monitoring done. And unfortunately, often that gets missed, or there's some miscommunication, or they do it for the first little while, and then after that, it's not continued. So I really appreciate all the patients today talking about how important it was to get monitoring, because that is, even if you're not treated, that is really very, very important.
Thank you. Dr. Ma?
Yeah, so I agree with everyone, and thank you for inviting me. The challenge is that actually a little bit more complicated than that. So when someone go for blood test, ultrasound, they might need time off. If they have to come into the city to see a specialist, they need time off also. So it's a little bit complicated. The cost of the medication is a challenge. And it's not just 6 months, a year, you're talking many years. And that really add up in the long run. So those are all the challenges, thing that sometimes we don't appreciate from a physician perspective. And from the patient perspective, they want to do what you want them to do, but it might not be possible for them to take time off. And sometimes we even agree to see patient at 7 in the morning, just before they work, just to make it easy for them. And unfortunately, in my practice, most are immigrants, and they don't really get the kind of support as in a lot of the Canadians. And even their health insurance, medication coverage, they may have medical coverage, but they have a limit in a year. So it doesn't take long for them to use their limit.
Maybe, if we can do more like in virtual care, like that is, we've been able to do more of that now after COVID. So at least we're able to help reduce the challenge for people having to take time off of work or drive to the hospital and pay for parking and all, and get somebody to take care of their children while they go for their doctor's appointments. All of that can hopefully reduce these barriers to care.
But there's a challenge.
Yeah.
Let me just say, after all these years, the viral load ALT, they are very deceptive. And the FibroScan is helpful. Perhaps if we have funding for ELF, we can certainly completely do virtual. Because sometimes if you do the test in the wrong time, your ALT might be quite good because they can go up and down. And but if you have a FibroScan to go along with the blood test result and symptoms, then you are quite reassured that whatever approach you're choosing is working.
David,
I think I think it's important to be flexible in what we offer. I have patients who they want to be in the clinic every single time, and they'll make sure that the blood work and the ultrasounds are done no matter what. Other people, they'd prefer to have a mix of in-clinic and hybrid visits. They'd prefer to have their blood work done at an outside community lab, and same thing with their ultrasounds. So we try to respect that and as much as possible, sort of facilitate and provide a model of care that really fits with what the patient desires. Having said all that, I think we'd all agree. Uh, we feel a little bit better about the quality of care if we see the patients in clinic, more often than not.
Thanks,
Yeah.
Curtis. Carla, maybe I ask a question before I ask David and Scott about the challenge, because one comment from the chat, it says sometimes we refer back the patient to GP, say, "Could please continue with blood work and ultrasound." It seems like that sometimes there might be some reluctance. I felt like the GP is like, oh, not willing to send them for ultrasound and blood work. So I don't know whether the other like Curtis and Meng heard that from the patients and what could we go around and maybe need more education to the GP. So I got challenges too, because a lot of GP, many patients in BC, they don't have family doctor. We cannot refer back, but it's a lot for us, and we don't have a kind of automatic ultrasound program. So if they don't call me, need a ultrasound form, it's like delayed by 6 months or a year. Sometimes hopefully not bad things happen, but it happened that many people miss that supposed screening.
Yeah.
Did you want me to respond to that first? Or so yeah, that's a very, very good point. So if they don't have a family doctor, we keep them in our clinic for follow-up until they can find a family doctor. But we've been lucky in Alberta to both have the automatic referral program for ultrasounds, and secondly, we've been able to work with primary care to develop these pathways. So Mang did the first MASL pathway. I've helped with doing the hepatitis B pathway. A lot of times it's not necessarily the GPs not wanting to do the monitoring, it's that they don't know exactly what they should be doing. And so having very clear pathways to guide them about what to monitor, when to refer, we hope will be helpful. It's still being piloted, and we're going to try and gather feedback about the success of the pathway.
Thank you.
So
Curtis,
So I'm very sympathetic to the workload of primary care providers out there. So there have been circumstances where I'll say to a patient, look, you're very straightforward and stable. We'll ask your primary care provider to follow you, and then they can refer you back in a couple of years. And 3 months later, I get the referral back saying, look, from the primary care provider saying, I'd rather you follow this patient. And so we do. We'll follow everybody. And as Carla said, if they don't have a primary care provider, then we continue to see them. But it does raise issues about capacity because, I don't know about your clinic, but we get, multiple new consults every week. And currently it's a chronic infection. So, our numbers get bigger and bigger and bigger. So, trying to think of maybe shared models of care where we're still engaged, but maybe not as frequently as every 6 months or every year, would help with our ability to see everybody that needs to be seen.
Thank you. David, I know you're smiling when Curtis saying a comment.
I'm going to take a different approach. I'm going to say that I have really no challenges for the people that come down to see us. Our clinic runs very efficiently. We can see a ton of patients, but it has to be said that the patients that come to see us are super motivated. They don't mind the high parking fees, driving 2 hours. They don't mind doing blood tests in our labs. So for us, like with the EMR that we have, it's super, super efficient. There's actually really, honestly, no challenge. The cost of medication is a problem for some patients, but a lot of patients now have coverage. The bigger problem is that we are only one place. We can only see so many people. We can't see as many people as we want if we are training people, training doctors. So training doctors takes a huge chunk of time out of our clinic access. They actually slow us down considerably. So, and despite our best efforts to train people, a lot of people leave us and don't want to do Hep B. So I think the challenge for us is actually the challenge for me is to help develop a better system. Because as you may know, my expiration date is in under 4 years before I retire. So that clinic will close. And the challenge is to develop an AI. I don't think guidelines and pathways will work. They have consistently failed us. It's always a disappointment when I try and discharge patients. They always end up coming back with inadequate follow-up. And I think it's gotten to the point where everyone's so busy. I mean, you have your pathway, but they have 50 other pathways to follow, and they can't keep up. And I think the only way to make this work is computerized models and AI models. I think that's where we should be. We should be actually saying, let's put this, it should be very easy to put a guideline into an AI and then an AI to guide management with primary care.
Thought you work in the same liver center as David and also do a lot of teaching. Like, how do you feel about the challenges in managing the Hep B patients?
Well, hopefully I'm not retiring in 4 years, so I think I'll still be around for a
Less
few
than
more
4 years.
That's your clinic, yes, but yeah, we face the same challenges. I do agree in large part, but I think yeah, sometimes with the standing requisitions, a lot of help from NPs. And some of our fellows are interested in hepatitis B, but you're right. It does take time to train them, but better delivery and better models of delivery of care, hub and spoke models. I think it just takes a long time to get where we want to go with many of these changes in care. But certainly Epic and different EMRs have made it a little bit easier. And they're not perfect, but again. Yeah, it does require, I think, more investment in training the next generation.
Curtis.
So I truly hope that Scott never retires because I need somebody to keep me company.
He
Um,
sees 70 patients at clinics. So like when this generation of doctors retires, it's going to be hard to keep that volume up.
Just looking forward to, hopefully we have newer hepatitis B therapies that can accomplish a lot more. So namely clearing the surface antigen and allowing people to come off of the oral nucleosides. That'll be great for patients and hopefully reduce their risk for future liver cancers. But these medications, at least initially, are going to be very time consuming for the physicians and nurses and other healthcare providers to administer. So we need to start thinking now about how we're going to work this into our clinics. We also need to think about what we need from the labs. You know, if we're administering medications and the idea is to clear surface antigen, we need timely, reliable, serial way surface antigen measurement access, which most places in Canada don't currently have. So again, now's the time to try and get the infrastructure in place for when these new exciting medications do become available.
Dr. Ma, Meg?
So hepatitis B is a little bit unique in the sense that it's complicated, and the DNA will go up and down, and sometimes their fatty liver ALT might be high for other reasons. So for primary care, if their practice has 1 or 2 patients, it's really hard for them to gain the experience to look after them. So the challenge is really more than just sending the patient back to primary care. And the challenge is really have a program. We don't have to be physician, nurses, nurse practitioner that can really help to monitor the patient. And when the patient get a little bit, the clinical history change, then it could be seen by specialists. But the challenge is that, I mean, I don't have a funded nurse to help me. And there's so much time in my clinic that I can see patient. So it's a challenge. And some primary care physician we work with, they're very experienced, but majority actually don't have the experience. And to rely on them to follow would be a little bit unfair to them.
That is certainly true, but I think that there are many primary care doctors, at least in my experience with working with the Alberta Pathways Unit, they are interested in learning more about hepatitis B and understanding management. They are used to taking care of very complicated patients, like, you know, managing a complicated diabetic patient with multiple different medications for diabetes could arguably be equally as challenging as ensuring a patient has an ALT and HBV DNA done every 6 months and have a regular ultrasound with very clear instructions of when you should contact. We have Specialist Link, that's that 5 days a week phone service for them to contact the hepatologist on call if they have questions. So there should be a safety net for them if they have questions. And the other point is that our patients or the community can be educated. You can see from the people that we're speaking today, they know very much about what should be done and what should be looked at. And so we should give them the knowledge so that they are empowered to ask for these tests and to ask and speak to their doctors about it so that they can get the best treatment. And so hopefully this community forum is the first step to giving more knowledge and power to people so that they know what should be done.
Now, Colina, I mean, if you want to wonder, any patients in the Toronto site have questions to ask, because I mean, really sum up very nicely all the challenges we see as physicians but I mean, I also see in the chat that some people about the access to care, the barriers. I mean, it's meant to be interactive, but if someone like even patient has like on site.
Sure. I can ask the audience here, but before I ask the question, if I can just pitch in from my years of experience looking after hepatitis B patients. I mean, in terms of capacity, it's the same. Like, I have worked in a liver clinic with all the liver doctors for many years, over 3 decades. And I also have reached the capacity. And I have patients asking me, well, please, okay, refer me back to the community. And that's what I did. But many of them return. is that I want to come back to see you.
I
So
mean, come to me because you're gone.
so I give the Dr. Wang all my patients and Dr. Scott as well. But anyway, so yes, and is it only the capacity issue or like so many of these patients, they don't mind to commute anymore. And they say, well, I want to see you because I get more information from you. So that makes me wonder, like, we definitely need to educate our family doctors. So maybe it's not that they don't know about hepatitis B, maybe they got a bit intimidated in a way. Is because, well, I don't know what happens if, like, they don't take the drugs or they don't come for ultrasound. So I think we need to educate them a little bit better. And just and another challenge that I find is in clinic, I only have a limited time per patient. So I always feel I don't have enough time to talk to the patient. I know that patients have questions. I can give you actually my personal experience, the reason behind why I started a peer support group in Toronto Liver Clinic. I have a patient who I look after, like a patient with hepatitis B, I look after for many, many years. And then come one day, and then she asked me, Kalina, what kind of viral hepatitis do I have? I said, oh my God, like after all these years, I have not made myself clear so that the patient does not really understand. Maybe like, we just assume that they understand, they remember, they know, but maybe at the end they don't. He said, well, I'm in good hands, I'm in your hands, I'm in treatment. So, and they forgot, and they got confused because at that time, there was all the hype about hepatitis C. So the patient
Yes.
got confused. Okay. So, I mean, that is the reason behind. I said that, well, we as healthcare providers, a lot of the time, we don't give our patients enough time to ask questions. And so I think this is why the support group, like involving the communities, involving the patient's family, is so, so important. So that's my little blurb. So I actually see on the chat, Victor Chan, like Victor who shared his story with us before, has a comment. Hin Hin, do you want to
Yes.
say
So
that?
Vic was saying, shouldn't be note that, of course, as David mentioned, people come to the clinic and seeing specialists. They're the motivated patients who probably care about their health and probably read about the condition and will follow the recommendation. But basically, the ones that maybe don't know they have it and maybe not linked to primary care or specialists, that probably are the one that have maybe more affected. I mean, it is talk about just like many other conditions we had, like a lot of barriers or linkage to care gaps. We see a lot in Hep C, definitely in Hep B. I think kind of tie back to Colleen and what you mentioned about the educations. I think we all kind of add quite a bit of our capacity. There's so much we can do, see, unless we can clone ourselves, we won't be able to see everyone that we wish to and spend enough time, right? So I think hopefully then I think we're good segue. I think maybe we do need a separate patient education for I mean this one we really hope to do it on an annual basis, but I think even like for a nurse practitioner and family doctor to, if they're interested, to really educate the Hep B, especially with potential new treatments down the road, so we can have more people interested or their internets, they're interested to really help to teach them and about the Hep B so they feel comfortable. Only refer the one that more complicated, not comfortable, to like tertiary center because there's only so many of us to see.
Well, but I think you should only refer if your patient is interested, because I have had referrals and I look at the labs and I'm terrified, and it takes a lot to scare me. And I call them up, but then they tell me to go to hell. I'm not interested. Right. And we reach out to them many times and they just say, no, like they're clearly young and cirrhotic and active. And like the mother said, no, go away. So there's no point in referring someone if they're not interested. It's true for Hep C, it's true for alcohol.
So, I'm going to have to
David
provide a
disagree?
different.
Well, if you have a lot of slots, Curtis, I'll refer all my uninterested patients to you.
Well, I'd be happy to see them. So
Okay.
yeah,
They have to travel to Ottawa, though.
we're all very busy, but another way of looking at this is an opportunity to try and at least plant the seed. that, maybe they're not going to be ready for therapy at the first time you see them, but you establish the rapport. Maybe those sort of trust barriers,
No, they don't even
they
want to
start
come and
to
see
drop.
us,
And
Curtis.
then eventually ultimately we want what is best for our patients. And sometimes that takes longer than the first visit. And ultimately we may be successful in getting them onto therapy that we know that they'll benefit from.
So I think if you're aiming for 100%, you will never achieve it. You can shoot for it. But given that we have capacity issues, it is not worth referring someone who's not interested in coming because they will block access for somebody else who is interested in coming. So it's something else to consider.
Although the thing is, sometimes you can eventually convince them. So if they do come,
I can convince them if they come, but if they're no show, no show, no show 3 times in a row, how many more times do you want to refer them?
Sure. So
Right?
that's a different,
That's different.
people have declared themselves
Yeah.
after
If your patient
two
says to you, I
times,
don't
then
want to
it's okay,
come, don't
that's
refer me,
fine.
then why
Yeah.
refer them?
Well,
Yeah.
yeah, if it's 3-time no-show, then we say you have to be re-referred. I'm declined, I guess. That's what
You're
happens.
too nice. I say don't re-refer. Okay.
Mhm. Yeah.
But I think it's also important to realize that by not seeing those patients, eventually they will show up and be costing more healthcare resources. So the important thing is really not from the physician perspective, they are not coming. Perhaps we have to address from the patient perspective how to reach out for them to understand they need to be seen or followed. So we only, a lot of time it's easy for us to say, well, they no show and I'm not going to see them. But perhaps there are other reasons, perhaps there are way you can reach out to them. And because eventually some of those patients will show up either with cirrhosis complication, liver cancer, or they're in trouble in need of a liver transplant.
Mang, I was just going to add, I think, yeah, that's very important because we're at a peer support, family support group. So it's often very helpful to have the spouse or another family member come along with them. Sometimes you're right, they only come alone or they don't come at all. But often there is a spokesperson for the patient. It's usually the spouse or the concerned person who sometimes does all the talking and will do a lot of the groundwork to get the Trillium or the private insurance in place.
And they're not coming for a reason, not because it's just they don't want to look after themselves. So a lot of time is really they cannot come for perhaps if they take time off, they're going to lose their job. And there's a lot of reason. And to drive 2 hours to see you, David, and then they have to drive 2 hours back home. So essentially they lose a whole day of work and not getting paid. So
Language barriers, social barriers, we try to remove as much of that as we can by
those are
having interpreters or having the iPad ready, but or having staff that will speak whatever language the patient is.
You guys are clearly too young and still overly optimistic that you still try
I'm
for
not
your
young. Hey,
100%. And
I have
perhaps you should try and look after some people with
Hey.
alcohol use disorder so you can get a better perspective. You still
Well,
need the patient will to do the stuff. You cannot look after people who don't want to be looked after.
let's just say absolutely don't want any care. They're a very small number.
Yeah.
But
I
definitely
expect-
the alcohol patient population is very different from the hepatitis B
No,
population, I
it's
will
people
say.
are people, right? So you can't have this rose-colored vision of people with hepatitis B. There's many people with hepatitis B come from many different walks of life, have very many different perspectives. All I'm saying, I'm not saying don't give them care. I'm not saying don't try. I'm saying be realistic. You will not reach 100% no matter how hard you try.
Yeah.
So you might not reach 100%, but if you reach 90%, that would be.
Meng, I'll refer them all to you. I'll say, hey, here's a ticket to Alberta.
Well, I mean, we had
be-
Biniam. Biniam was here earlier talking about his experience working with the refugee clinic. I mean, he's a perfect example of how peer navigators can help with getting people into clinic and making sure they have regular follow-up and monitoring and understand. And so,
We're talking about different things. I'm not saying don't try, but when the patient's mother tells you to go to hell, that's saying something.
Oh, David, I do want to share a story. I do see, this is when I first practiced, see a gentleman clearly need Hep B treatment, active.
Yes.
And but he equated as called chemotherapy. So I went into, because I'm so naive in my practice, heated argument on the phone and talked to patient. I said, "Why you're not on treatment?" I was really getting emotional about why he's not. So he still see me. So I kind of keep following that. I know he clearly not follow my recommendations. Of course, unfortunately, he did develop HCC and he got resection, but afterwards he agreed to treatment and I followed him and I mean he changed and I'm not going to bring him back to the old story. So it just takes time. This is over 10 years. So finally he agreed to treatments and he changed his view. So I think persistent and patience do help. I guess ultimately it is the education because I think
Yeah, you give them the opportunity, but in the end, you can't force them, right?
yeah.
It also reminds us all that every person is an individual. They
Yeah.
have their own
I think there's a
history, their
patient
own
that
challenges
has
and
a question.
desires.
Yes.
And so that we need to be flexible and accommodating to try and find that formula that works for them. And sometimes you're right, David, sometimes it won't work out.
So I can give you a cautionary tale because I think we always try to let the patients have their way and have their say. But I do know of a case where they did that and the patient declined antiviral prophylaxis for reactivation. And then the oncologist did their thing, but the patient died from reactivation. So there are limits to accommodation.